time and energy. You can't help but think of that affects you in some way, and certainly affects everybody. Makes some people, probably they're not their best angel, their best self every day, and as a result, we need to enter into this conversation of professionalism. Now, I have no disclosures to make except to say I'm a great fan of Pixar, Disney, and anything Apple. Can't wait till the Apple Watch comes out. The images that you might see are going to be borrowed heavily from the movie Ratatouille. And if you are a parent, you've probably seen this movie many, many times. If you are not a parent, if you have no children, if you have no interest in anything small, it is still a great movie to watch, and I would commend it to your viewing list. But I will cut to the chase to take a moment to look at the take-home messages that I want us to have over the next 25 minutes. And that would include identifying the impact of unprofessional behavior, secondarily, accepting responsibility, if not trying to be our best selves at all times, but also if we see something happening, that we actually intercede to try to change that environment or that behavior. And finally, to incorporate some of these elements into our daily lives or practice. We start by posing the question, what exactly is disruptive behavior? And what I would ask you to do is probably think of an image of a person who, if you are to get your list for tomorrow, and you're reviewing who you're going to be working with, the rooms that you're going to be working with, who you most desire not to see on that list. We all have those people, right? We're coming in, flying back after this conference, Monday comes up, we say, hey, what's going on? And we look at it and we're like, oh man, this is going to be a tough way to start a week, right? And when we think about that and this definition of disruption, we can certainly look in a dictionary, but to sort of operationalize it, to picture that guy that we're trying to avoid. Does anybody watch the Food Network or, cooking shows? It's kind of interesting that certain industries seem to embrace this dysfunctional character. If you have ever watched Gordon Ramsay on the Food Network, this guy has 12 restaurants, 15 Michelin stars, 8 television shows, 5 books. He was just given the Order of the British Empire by Queen Elizabeth. So by all effective purposes, this guy is on the top of his game. And yet, as you watch what he does during his TV shows, he is vitriolic, he is throwing things at people, he is making sure that they know what he ate for lunch because he's that close to them. He throws people out of his restaurant. I have a number of friends that work in food service, and they say this is not atypical for our industry. And we pause and ask for a moment, is this the same sort of behavior that we should expect or want in our industry, in healthcare? And I would submit that it isn't. And in fact, to operationalize this a little bit further, Joint Commission is very interested in this whole process, in part because they recognize that disruptive individuals will ultimately affect patient safety. And we'll move through and we'll understand that path as we look at the different pieces. But what we have done at our own institution is we say that these individuals create an environment that diminishes that relational trust that we have between providers, or between us and our patients, or between us and the institution. And ultimately, that adversely impacts our way of providing care. Now, it's interesting that some individuals will think about how they act and will not characterize their behavior as disruptive. And we sometimes present a list similar to the one that you're seeing now to different individuals. They'll say, yes, this is the way I work, this is how I operate. Sure, some of the comments that I say and how I act could be perceived as some of this, but I'm not a disruptive individual. And they sort of confine their mind into thinking, I want the exact episodes of when this occurred, I want to know who reported me, I want to, and they fight it tooth and nail. But then we say, well, your own societies have defined these as being disruptive behaviors. And when we interview individuals that have had contact with you, they represent your activities as being unhelpful to the care that they're trying to deliver. So, a question for all of you guys. In the last 12 months, have you witnessed disruptive behavior? Can I just see a show of hands, okay, in your work environment? Good. How many have experienced it personally? It directed to you or, yeah, okay. And then how many have gone ahead and reported this behavior? Okay, so some. And as we see in my view of the audience here, is what we would expect, that many people witness it, fewer people have directly experienced it, but even fewer report it or try to do anything to change that behavior. And that's something that we need to have some awareness to and something that we have to change. In fact, but it's very consistent with national trends. If you look at some of the literature that's out there, roughly 90% of individuals have experienced this disruptive behavior, sometimes directed at them, and sometimes it stays certainly in the verbal sense, but it can subtend into the physical sense as well. So what's the problem with this? I submit that it has probably 3 levels of disorders that it can create. Now, the first is, as you pull that list for Monday morning, you think, yeah, man, I'm working with him. You can imagine that you're probably not going to talk about all the great things that you've done this weekend in San Francisco. You're probably just going to try to do the case, try to keep your head underwater, try to not antagonize everything, just kind of work the day through, and hopefully it'll be a quick day, and at the end of the day, you're out of there. You're not going to enjoy this friendly banter of someone who you really enjoy working with and who you can't wait to see, and every time you get together, you think, man, that was a great day. That day went well. And it can promote hiding mistakes. For example, if you're working with a surgeon who at the last minute says, well, on this patient, I don't want Toradol given, for perceived, ooziness, but you see nothing different, but you've already given the Toradol, and this person's going to go ballistic, you're probably just going to go, oh, yeah, nah, no Toradol, yeah, right? So that has now engaged in something that might have affected care at some level. It does reduce collaboration. Well, let's look at a second level, and that's it could create errors. For example, I work with an orthopedic surgeon who goes absolutely ape if the blood pressure is 10 millimeters of mercury greater than he wants. He thinks that the hip surgery is all about where the anesthesiologist can place the blood pressure, And so we have an art line in place, we're going along, and pressure starts increasing in this elderly individual that's poorly controlled hypertension. And that art line transducer is just begging for me to do something with it. It says, I have been neglected during this case. I mean, I want you to play with me a little bit, move me up and down. And you can't, deny that sort of hesitation or that sort of thought maybe creeps into your mind because you know that this individual is just going to go and act a certain way. And ultimately, that could affect patient safety if there's subtleties in like neuromanagement or some neurologist is about to do a clipping and you're moving around the transducer so it looks good, we have to think about that. But there is a third level, and that level is how it affects people that work in that environment. And when we think about this, I think of a case that we had where we had a nurse that really detested working with a particular surgeon. Now, I'm not picking on surgeons because they're the only ones that are bad, but that's where our frame of reference is. We work with a lot of surgeons in our work and our care. But this particular nurse said that every time she was assigned to work with a surgeon, she would try to make a switch with one of her colleagues. Now, a lot of people didn't like working with the surgeon, so that proved difficult. So she started calling in her sick days. When she exhausted her sick days, she started taking vacation days. When she exhausted her vacation days, she decided to take a leave of absence. She was so powerfully changed by her interactions with this individual. She said she would go home crying every day after she worked with him. It was just expected. And she said, and when she didn't work with him, she would just say prayers for all the other people that had to work with him. And this is not the type of environment that we want to create and emulate in our institutions. It can institute other issues as well. We had another surgeon who really belittled the work of everybody that he worked with. In fact, his turnover time was about 42 minutes. It was twice our average for our operating room. And he came to us saying, people are working against me, and so we looked at his turnover time, and indeed they were higher than everybody else. And when we interviewed all the people in the room, they said, yeah, I intentionally don't work hard because I hate the guy. The people that clean the room, they said he will sometimes come in, pick up the mop, swiggle it around the room, toss it in the corner and say, your job is so simple, why can't you just do it? And it was that sort of behavior that we said needed to change. It was him that was actually driving the dysfunction in the room. We have worked with him. We sent him away for some beauty camp stuff, and he has made an improvement. And his turnover times have made an improvement as well. So that's one benefit. And then ultimately it can affect litigation. Here in California, there's a great example of a OB who wasn't being called by a nurse. The nurse, and you can read the transcripts of the case, said that every time she called the surgeon, the obstetrician, he would call her stupid. He would say that she always seemed to call him at his most busy time, that she called him for information that was non-useful to the case that they were dealing with, and that it wasn't important to the care of the patient she was taking care of. So for a tracing that she saw that she had called him before and he never responded to, she said, I'm not going to call him for this one. Kid ended up with cerebral palsy, ended up with the judgment against the two individuals as well as the institution. Damaged baby claims are among the most expensive. But there's other examples, nurse-to-nurse conflict, physician-physician conflict. I was just down in Southwestern about 4 weeks ago where we talked about some professionalism issues, and they're just resolving the case that's listed right here financially. And it's something that has long legs to it. But why we're most concerned about this is that because behavior is learned, and it is contagious. If someone thinks that Mr. X or Dr. X or nurse or whatever is getting away with this type of behavior, is training other people to be like that, then they'll think this is the culture. And indeed, habits and culture can be formed. I don't know if anybody knows the writer, author, Harvard Business School professor, Clayton Christensen. Does this name sound familiar with anybody? Clayton Christensen is a Fortune 500 consultant. He's been at the business school for some time. An interesting thing happened to him. I was able to sit down with him for about an hour. I was taking some coursework over at the business school. And he had a stroke 3 years ago. So this was a guy that had all his capabilities. He was a communicator, an educator, someone who talked to corporations. He needed that ability to talk. He lost it 3 years ago when he had the stroke. And thinking that that might be his last opportunity to start writing down his thoughts for his business colleagues, who, when he went to his reunions at Harvard and also Oxford, he saw people getting divorced, people being estranged from their families, people being in jail because of white-collar criminal crime, as well as being fractured from their businesses. He said, I need to write my lessons of life that have been important. He incorporated this all into this book, How Will You Measure Your Life? It's worth a read if you want a good book to pick up. But essentially what he says is all of us carry around a culture within us. And we allow that culture to either be expressed to the people around us, and we allow it to grow in that way, or we let it be shut down. He said, and I want you to be people that can really carry that forth. That set of culture that is moral, that is of good character, that is of trying to help other individuals, and let that principle and people the lives of the worlds around you. Okay? So how do you change the rat? And that's the primary motivation that we have here. And I have a case for you to think about. You have a cesarean, it's extremely busy, you're being called for epidurals. The patient sounds like Precious that we had the other day, grew up. Now she's in another pregnancy. She has gained weight from where she was before. She's now a malpractice attorney, and she's married to a dermatologist. And dermatologist husbands or spouses, I hope none of you have them, they seem to know much more about anesthesia than you do and are quite willing to share that with you. But you have Dr. Hodad who works in your institution. Now, we all have a Dr. Hodad, hands of death and destruction, right? And he charges in, takes command of the situation, causes you a lot of grief and everything. And this is what he says. And so you pause for that moment, and you're considering what your reaction is going to be. And any moment we're faced with this event, we can either get into a fight, and there are some examples of that, and I'll have you read through this if you wish. Now, I won't say this is totally devoid of professionalism. I mean, the nurse did monitor the anesthetized patient, right? That's good. That's good. And the doctors did resume the operation. So, you know, we're good. We're good to go here. But it's amazing that it can come to fisticuffs. And I mean, we don't have the only corner on the market here. There's a case that's working its way through the courts in the UK. Exactly the same thing, fisticuffs in the operation. So it's pretty amazing that these expressions of angst can come to the point where we're wanting to engage in a physical event. But that's probably not best for your career. And I would submit that what many of us do instead is flight. We see something happening, it happens to us, or it happens to one of our colleagues, and we just say, man, that person is always going to be that way, they're a jerk, I can't do anything about them. And so you just move on your way. And I would submit that there's a third way, a way that is more right. And that can involve health systems, institutions, all the way down to an individual level. And that's what we can think about and talk about now. There's a lot of governmental agencies that are now being involved in this, Joint Commission certainly. A lot of different societies are issuing statements about disruptive behavior and creating positive work environments. And at your own institution, as you look around at the individuals, hopefully there's going to be some source of a code of conduct. And we at our own institution decided 5 years ago to set up a Center for Professionalism and Peer Support. I'm the associate director of that center. We have a surgeon, and she's the director. And essentially we created this code of conduct, a reporting system, a method of investigation, as well as education. And just to tell you a little bit about that, how it works is if we receive an anonymized report, we talk to the individual, we then do multi-source interviews, in part because we want to determine whether or not this sort of behavior is just directed towards one particular group of people or certain racial or ethnic characteristics, or if it's hierarchical or whatever. And then we meet with that individual and a person of authority. If it's an individual practitioner, it's usually with their department chair. If it is the department chair, it's with the chief medical officer and or the president of the hospital. And during that conversation, we say, we recognize that some of these behaviors are very long-lasting. I mean, some of these people, when you think about it, they've been bullies since kindergarten, and this has just followed them all the way through. They know that aggressive behavior works for them, and as a result, they're going to use it in every opportunity. And so we say, this is a time that you can evaluate your own sort of behavior, and we're trying to give you an opportunity to change that. Because if you can't change that, then we're going to probably ask you to take your talents elsewhere. And some of this means behavioral counseling, and some of it also means sending them away to an inpatient 3-week residential behavior counseling system where they really get the message that things need to change. And we make it a third in terms of the costs. The institution pays for a third, department pays for a third, individual pays for a third, in part because that puts more skin in the game in terms of their willingness and their desire to change. And we do follow-up, we do evaluations, and we consider how they're doing. And just to share with you some of our results that we recently published in the Joint Commission's Journal is some of these cases, when reported to us, were unfounded. We recognize that they identified the wrong person, or it was just a misunderstanding that both parties agreed is not a big deal. Some individuals resolved with just a single sit-down. They saw the light and they recognized how serious we were, and they didn't recognize that someone was actually watching them. And sometimes it meant just interceding on behalf of the individual. We had a junior surgeon who was very good in residency and fellowship. When he was first year junior surgeon, he was just a terrible guy. I mean, he has full of stress and angst and everything. And what we found out was because he was junior, the only surgical block he got was Tuesday early afternoon, but his clinic was at Tuesday late morning. And there was always this conflict between the clinic and the operating room. He's being called in the operating room about clinic patients that ran late, or he's being called from the clinic about different things while he's in the operating room. It filled him with a lot of tension. We talked to his chief. We separated those 2 dates, and he's a remarkably changed person. We are improved, and we are following some individuals, but we are not afraid to remove individuals from positions of authority. And if you look at the roster of departmental chairs or scientists, that some have brought millions of dollars to our institution, who have left our institution for personal reasons or in pursuit of other opportunities, you will find some individuals that we have talked to. And we have sort of motivated their change in employment. There is, of course, the divisional response, and this is not to say, my people mess with you people, but it's to say that the division represents an opportunity for change. And one example of this is at Mount Sinai. Their transplant service got shut down in 2004. The OB service, recognizing that they had similar degrees of dysfunction on the labor and delivery floor, decided to institute a culture of professionalism, a reporting system, and an educational system. And what they have found over time is that overall teamwork on the unit has improved dramatically. The managerial support of looking into individuals that are considered disruptive has increased dramatically, as well as the overall organizational learning. Mount Sinai has been doing this now since 2005. They've reported surveys, and I was just down there about 6 weeks ago, and they're still using this process, and it's still working quite well for them. We've engaged in a similar process on our own labor and delivery floor, and Mike Orozco, who's going to be following me, has instituted something very similar at Kaiser as well, where we have interdisciplinary rounds as well as pre-procedure huddles. And what we have found is this has engaged people to reduce practice variation, to come together, learn names, reduce hierarchy, and overall function better as a unit as a result. And then the individual response, and this is probably the most difficult thing. I mean, yes, our intent is to deliver great health care in an agreeable and a nice fashion, but sometimes, we get stuck in traffic, we miss our favorite coffee, kids are going crazy in the morning, the weather in Boston, 8 feet of snow, that stuff gets in your way, and all of a sudden you're slightly on edge when you arrive to the workplace. And so here we have to remind ourselves to really be mindful of the words and the way that we communicate information. And I say stay in the present when you're dealing with someone that you have had poor interactions with in the past. And what I mean by that is it's too attractive to bring all the past offenses that that person has done to you or your service into this present conversation or conflict that you're having. And instead, pretend like you're meeting this person for the first time, that you don't know the person, that you're trying to do what's best for the patient. And don't project into the future where you're saying, the guy's a jerk in the past, will be now, will be in the future forevermore. This is not one of those things where you can predict in the future or should not predict. Offer the opportunity for a different approach. Focus on behavior because all of us have the intent of doing something good. Document behavior that comes out and report it in some fashion so that when you have this registrar of all the different offenses that the person has, that's a more effective tool to actually creating change. When you do have a conversation, if you need to bring it to this particular situation, invite them into a neutral space, really share the impact of their behavior as well as share your perspective. Also invite their perspective as well, because most likely there is a third story. Between your side and their side, there's probably the truth. And your mission is try to at least be aware that that truth might be something that is more valuable and ultimately can bring you both to a place where you're more agreeable with each other. and then amplify your conclusion. If you find that there's some deficit in the system that you can help change to eliminate some of this aggression, some of this behavior, then indeed try to do that in your possibilities. So to incorporate these concepts together, we have to think about, am I a role model? Do I try to do the best I can every single day in every single situation? On a divisional level, can we do something greater than just myself? Can we work together to create a situation that helps all of us? On an institutional level, you can say, am I a change leader? Can we bring some of the things that we learned at these other levels into something that has a greater mission and a greater purpose? So the take-home message is, once again, identify the impact of unprofessional behavior. We recognize that disruptive environments are not the ones where we can do our best work. Secondarily, accept the responsibility. Recognize that we have to try to be better people every day, but we have to try to improve the environments in which we work with, and that includes identifying those people that cause a lot of disruption so we can engage and change. And finally, incorporate some of these concepts into your daily life. I'll look forward to the questions that you have. Once again, I thank you so much for your attention. You guys are a great audience.